Good afternoon, everyone. Welcome to Kidney Action Week and our session, Structural Inequities, Impacting Access to Transplant, Referral, Evaluation, and the Waitlist. My name is Mike Spigler, and I'm the Vice President of Patient Support and Education for the American Kidney Fund. The goal of this session is to give you an overview of the transplant evaluation process, discuss how people of color face added challenges accessing transplant, and share some recommendations on advocating for yourself throughout this process. We have a lot of great information to get to, so let's jump right into meeting our speakers. First is Dr. Dinashika Mahagatay. Dr. Mahagatay is an assistant professor within the Institute of Health Equity Research at the Icahn School of Medicine at Mount Sinai and the Barbara T. Murphy Division of Nephrology, and a general nephrologist. She engages in patient and community-centered, inequity-focused research around the impact of socio-structural factors and racialized medicine on kidney health and kidney transplantation. Next is Tamara Y. Walker. Tamara is a mother of 2 adult sons, an advocate and ambassador with several kidney patient organizations. She was uprooted from her hometown in Virginia to her family's hometown in Georgia because of the effects of hereditary polycystic kidney disease and kidney failure. She shares her experiences with autosomal dominant polycystic kidney disease, which is also known as ADPKD, 2 years on dialysis, a diagnosis of kidney cancer, and receiving a successful deceased donor kidney transplant. Now, before we get started, I want to encourage everyone joining to please type your questions and comments into the chat box, and we will try our best to get to your questions during our Q&A segment at the end of the talk. But to start us off today, I'd like to turn it over to Tamara. Tamara, you experienced some challenges after you learned about having kidney failure and needing to get a transplant. So I'm wondering if you could share with us some of your experiences and how you've worked to share your own story.
Definitely. Thank you, Michael. Well, my story is rather unique. I was standing in line at the grocery store when I began to experience some fluttering sensations that's in my abdomen, and that's after giving birth to my second son. So I thought it was related to giving birth. So I went in for a follow-up appointment with my OBGYN, and he thoroughly gave me an exam, but he just didn't know what it was. So he ordered me to go out to get a CT scan, and the report came back the next day that I was diagnosed with PKD, polycystic kidney disease, ADPKD, just as you discussed earlier. I was 25 years old at the time. I had 2 sons and very young. Next slide, please. All right, so I was told that there was no cure. I was referred to a nephrologist. Of course, the OBGYN doctor was not able to treat me. And so I was given a PKD pamphlet back then, similar to a one-pager. So there was no thorough education about PKD at all. My family was unaware about it. And the fact that it could be passed down from generation to generation. And so we had no idea that it was hereditary in nature. And so I was told again there was no cure, but I can continue being seen by that nephrologist. He would follow up with blood pressure checks and monitoring, and he could write me a prescription. And that's what happened. So I was sent away with just a script and that pamphlet. Next slide. All right. So I was experiencing, again, the same sensations, continuous ER visits because of ruptured cysts. Again, PKD creates cysts within the kidneys. And there was agonizing back and side pain, constant UTIs, again, those infections over and over again. So I was finally told by the urologist that I was nearing kidney failure and I would need a transplant. I needed to be worked up for the evaluation for a kidney transplant. And he said that was going to be very soon. So I would need to at least go and move, or he encouraged me to move to be near my family so I can get that support that I needed. And so I took his advice. I did so. Next slide. All right. So again, I was uprooted. That's about 300 miles away, 3 states away from where I was born, just to be near my supportive family, again, because of kidney failure, because of my disease. And I'm so happy that I did. Next slide. All right. So, as anybody who started all over again after relocating, there were multiple challenges along the way. I began work, but I was uninsured. And the state where I moved had no extended Medicaid at all. So, I had to reach out for charity assistance. And I was enrolled in a program, and they were able to help me. I was able to be seen by a doctor there and also get my medications, but it had to be at that clinic. Those doctors, they volunteered their time to see me. And again, I was able to get my medications, but only there at the clinic. So I was unable to access other pharmacies. And also the doctors that I saw, they didn't know much about PKD. They were not even specialists. Again, like I said, they volunteered their time, so they had to actually call out to other doctors to find out what to do with me. So unable to receive proper care, proper access to care, and they were not knowledgeable at all about my illness. So they were not specialists at all. Next slide. All right. So again, I was nearing kidney failure. So I began dialysis. Once I began dialysis, I asked to be referred for an evaluation for transplant. And this is my second time around. So the first time I was asked to at least find a living kidney donor, but I was unable to do so. And then I lost my job and so therefore did not have insurance. So again, I'm on the second time around. And once I go into dialysis, I'm asking, can I be referred to get a transplant? And so there were a number of requirements in order to do so. So I had to get help again from my family, my supportive family, also my friends, and even the neighborhood. So the community had to help me. There was fundraising that I had to do in order to raise funds to help me. And the transplant clinic that was about 2 hours away from me in Atlanta. So transportation definitely was an issue for me, especially the times where I'm unable to drive as well. Yeah, so that definitely was an issue for me. But finally, I was approved for the transplant wait list. Next slide. All right, so while on dialysis, believe it or not, I was diagnosed with renal cell carcinoma, kidney cancer. And so that was by my home urologist in the city where I lived. So he again said that he was unable to treat me. There was nothing that he could do. So he referred me out, and that's to Atlanta, again, about 2 hours away, to a specialist who was able to help me. So once I got there to that urologist, it was unbelievable. He says, well, what we can do is we can remove not just one kidney, but we'll remove both kidneys. So both of my native kidneys were removed. A bilateral nephrectomy is what it's called. And I'm so thankful that he did so, but I just had no idea that that could even be possible. But after 7 months after I recovered from that, I received a call for a deceased kidney. So I did get the transplant that I needed 7 months after that, again, from a deceased kidney donor. Next slide. All right, so I had been told over and over again, repeatedly in my hometown, and then here where I moved again, that there was nothing that they could do, absolutely nothing that the providers could do. And so I was also told again that the symptoms were unreal, believe it or not, and on more than one occasion. I was told it was all made up in my mind, the symptoms I was feeling, and who knows, but that that happened to me. And so at times my complaints, they were overlooked, and sometimes they were shunned and dismissed, which was very frustrating for me and also for my family. But in return, what I did was I became an ambassador, an AKF ambassador, an AKF kidney health coach, an advocate. And what I do now is share my story with my community, with my friends, my family, and online, and also in peer support groups. And I'm so thankful to AKF that they're able to give me a shot and give me a chance and the opportunity to do so. So that is my story.
Thank you so much, Tamara. I mean, honestly, your story is so inspiring, and the fact that you had such a long journey is really something that I think hopefully people can take some inspiration from. You know, you have a supportive family around you, but really, how you talked about being your own advocate, the amount of times you said, I asked, right? I mean, I think you've heard that a lot today. And like, of course, tomorrow we have a whole day trying to help healthcare professionals, meet you halfway in that process. But until then, it's really important to be your own advocate. And I really appreciate you describing it the way that you did. If you're just joining us, please drop in your questions in the chat box. We will get to those at the end if we have some time left over. But I want to move right on to our next speaker. So I'd like to turn it over to Dinashika, who will be sharing about what the process leading up to transplant looks like, some challenges along the way, and in particular, she will share about structural inequities that lead to racial disparities in the pre-transplant process. I'll turn it over to you.
Thank you so much. I am just so grateful to be speaking after you, Tamara, because I think all I want to do is really highlight and elevate some of what you discussed. I don't have any disclosures other than advocacy for the National Kidney Foundation and some other organizations and NIH funding only. And so let's get into the meat of this. How can we finally transform this paradigm where we've been describing transplant inequities for now decades? I first want to highlight the importance of the story that Tamara shared and just say that unfortunately, this is part of a national sort of pattern and a national set of studies that show that across essentially every single type of kidney disease, there are racial and ethnic disparities that persist in access to transplantation, and autosomal dominant polycystic kidney disease is no exception. This was a really important study that showed that among a cohort of individuals with ADPKD, Black and Hispanic individuals were more likely to reach kidney failure faster than their white counterparts, but less likely to get a kidney transplant preemptively, meaning before starting dialysis, or even after starting dialysis compared to their white counterparts. And so this really requires our collective attention. And some of the attention that we've seen drawn to, these overall disparities is this focus on, what is really at the root of these racial disparities. We know that diabetes and high blood pressure are the two most common causes of kidney disease in the United States. And we know that both of those diseases are disproportionately found among individuals who are racial and ethnic minorities. But where in this conversation do we talk about the other social determinants that are burdening minority communities? Things like lack of access to healthcare insurance, lack of access to food and housing and transportation. And so when we're asked the question, is race the driver of risk, we need to be able to answer with a definitive no, that it is actually structural barriers that occur due to racism and other forces in the United States that result in some of the disparities we see. And so I think part of the solution is really identifying actual problems, actual structural barriers and harm, and avoiding what we've been doing in the past, which is saying, oh, it's a cultural difference, it's the way that you're eating, or it's because you're not taking your medications without asking why a person can't take their medications. And then this problematic implicating genetic differences as a root cause of these racial disparities when we know race does not equal genes. I think it's also important to highlight some of the successes of the past in terms of overturning some of the structural barriers. Hopefully everyone who is watching knows that finally we have now national ways of calculating the kidney function of individuals in the United States that do not include race. And most importantly, our transplant organizations have created a policy that should be restoring time to Black individuals who lost kidney transplant wait time due to prior use of race-based equations. This is just a critical message to get out to everybody and an example of how advocacy can result in policy change. But we have more work to do. Many of you may know there's ongoing advocacy to take the race and ethnicity modifier of African American out of the kidney donor profile index that actually grades the quality of kidney transplants that are available. So look out for more news about this. And moving on to sort of where these disparities have emerged from and why they exist, the truth of the matter is there are more people in the United States living with kidney failure, nearly 800,000, versus a number of individuals who actually get a transplant, which is about 16,500. And along the way, unfortunately, many people become too ill to actually get those transplants. And what's worse, and why we're all having this conversation, is that for 2 decades or so, we have been trying to tackle these problems. In 2000, there was a landmark study that showed that among individuals who are appropriate for transplant, Black individuals were less likely to be referred for evaluation, placed on the wait list, or actually get a transplant compared to their white counterparts. Now, the good news here is that some of these disparities have changed and improved with new allocation systems that give people time for example, their dialysis time is accounted for. But we have more work to do. And part of that work is educating people in the workforce about the fact that these disparities exist. This is a study from 2016 that showed that only 20% of dialysis providers in the country even know that these Black-white disparities exist in transplantation. We know, unfortunately, that discussions around transplantation as an option are unequal. So in this study from Baltimore, Black individuals, women, and people who made less than $20,000 a year were less likely to have a discussion about transplant and more likely to have one about dialysis. And unfortunately, disparities in living donor kidney transplant are unfortunately growing, and we don't seem to have made any progress in them in terms of Black-white inequities and who is actually donating living kidneys to friends and family. And what's important to recognize is that the barriers to transplant are multifactorial. They start well before the evaluation and referral process. So again, there's poor access to care and poor awareness of CKD and less discussions about CKD well before referral can happen. We know that there are disparities in referral patterns and education about transplant, as Tamara just described. And then at the level of evaluation, prior discrimination and bias in evaluation processes can influence some of the disparities we see at the end of the game. We also know, unfortunately, that the way that clinicians and providers write about patients really matters. This is not from transplant literature, but just overall literature. And it's a study that showed that compared to white patients, Black patients were much more likely to have an odds of having at least one negative descriptor in the history and physical notes. And the good news is that people are finally trying to pay attention to this and intervene on this. But it's an important thing to bring up because, as Serena Williams brilliantly said, this idea of medical mistrust can't be blamed for all of these disparities without understanding the root of that. The root of that is often a prior experience of discrimination or racism that someone had. In fact, that was shown in this study from Atlanta. So people who experienced discrimination before or perceived racism were much less likely to start their transplant evaluation process. So these things matter and these experiences need to be intervened upon. And in fact, our clinicians feel, the same sorts of challenges, right? So these are some interviews that we did in North Carolina, where general nephrologists were saying people who have the least resources are often suffering the most, and it's not fair that you can't get transplanted if you don't have a caregiver, et cetera. And so what are some of the things that we need to be thinking about intervening upon? It's each of these different inequalities and where people live, the kinds of things like tobacco and alcohol that are marketed in certain communities, access to clean water, and then economic inequities, educational inequities. Each of these things matters in kidney disease. And so some of the interventions that we ought to be focusing on is training clinicians to really provide trauma-informed care that is anti-racist and anti-biased, to make the evaluation process more transparent and accountable, to provide more incentives to centers to help donors and caregivers and recipients, to think about social support and the way that looks different across different communities and families, and to really get away from this idea that our patients are not adherent. Instead asking, why are there these challenges to transplant? Moving forward, we also can't ignore race, right? Because we have to understand what a person's self-identified race is or ethnicity is to even identify some of the disparities we see. When we were ignoring collecting data about race early on in the COVID-19 crisis, we were missing out on understanding what the disparities even are. And then we need to be training our clinicians to ask more about what their prior experiences have been and how we can help reshift the care trajectory and the care narrative. So really being explicit about the things that might have interfered with somebody trusting us and making ourselves more trustworthy. The Veterans Health Administration has been trying to work on that, really explicitly talking about how racial trauma has contributed to PTSD. We also need to be writing differently about people's experiences and their barriers in the medical chart. So instead of saying, oh, this person is late, really identifying in the chart, what their experiences might have been that contributed to being late. Here is an example here about stress that might have influenced this. We need to be getting out more education like this from the National Kidney Foundation and this wonderful programming through AKF to educate people about what their options actually are and the steps that are needed to get to transplant. And then finally, ongoing advocacy is needed to change policies. Here's just a couple of examples from New York City where I live, where there are attorneys who work to try to address barriers and get Medicaid expanded to cover transplant. Finally, we need policy advocacy around some of the forms that are being completed, making sure that our dialysis patients can tell clinicians what their challenges actually are, whether it's language or reading or housing or food, so we can capture and address those. And then finally, we need, structural interventions through things like community health workers who can address some of these major barriers around food and medication access and transportation. And the last thing I'll close with is all of us, particularly clinicians, need to do a better job of talking and writing about our patients in the chart. This is a great example of some materials that were put out from Temple about the kinds of language that can stigmatize patients. And now that patients, all of us, myself included, can read our charts, we should be holding our health systems and our clinicians accountable for this. I'll go ahead and close and just say thank you. Again, I work at the VA and Mount Sinai. I'm grateful to everybody who's contributed to the things that I've shared today.
Well, Danishika, thank you so much. I love your slides. It was a really great presentation. It's one of the things that our health equity program here, Kidney Health for All program, we have 4 pillars. Transplant equity is one of them. We're doing that with a couple ways here. We have a health equity coalition that we have developed a transplant toolkit ourselves. It's about to launch as well soon, but even our financial assistance program has been shown to really help with those inequities. Those that are getting charitable assistance from us tend to be upside down from some of these inequities we're seeing in the general population. We're actually presenting a poster on at the NKF meeting coming up in California, so we're excited to do that. So actually really, really excited about that. One of the things that you mentioned that I want to go to Tamara first on is just the whole idea of adherence, and that term can be used as a weapon sometimes, it seems, especially in this process. And we have talked to patients as part of this process where they've missed an appointment maybe because of all the socioeconomic challenges they're dealing with. They rely on bus transit, and that bus broke down that day. So Tamara, I'd like to start with you. I mean, how did you manage all of your appointments? Your pre-transplant, your post-transplant appointments, what was your strategy for taking on that? And then I'll come back and have another question for Danishika.
Again, it was my supportive family. So I don't know where I would be without my supportive family to definitely help me. Again, the transplant clinic is 2 hours away from me in Atlanta. And most of the time there's an accident. So we've got to leave 3, sometimes 4 hours before our appointment. So definitely it's my family who helped me along the way. I have 2 sons. My youngest son, my oldest son helped a lot with driving. He just gotten his license when I was called for the transplant. And so he was the one that was taking me back and forth to Atlanta, believe it or not. But yes, definitely. And to dialysis clinics, I had to call family on a number of occasions. So definitely family played a big part in helping me.
Thank you so much. Tanoshika, what do you recommend for patients doing this? If they've missed an appointment, because we've talked to patients from, they miss a dialysis appointment even, let alone, a pre-transplant workup appointment. How do you, what's your advice for how to explain that when you're talking to your transplant team?
Yeah, no, thank you for the question. I think that there are a couple of things. And first is recognizing that the system is ideally there to serve your needs, you, the collective we as patients, right? So letting a dialysis social worker, your dialysis team, your nurses, your techs, and your nephrologists know what the challenges are getting there and seeing if they can, essentially leverage either community organizations or their own resources within the dialysis unit to support them. But then I think the second thing is just being really explicit about what some of those challenges are if there is a missed appointment, or if, for example, somebody brings up this idea of, oh, well, you haven't been as adherent to X medication, being really clear with the transplant center about essentially, your desire to make this work and asking for support mechanisms that exist within the transplant center and through, again, our national organizations. So AKF, NKF, and other partners where there's peer mentoring and social support services. There are even in some communities, I have a colleague in Michigan who has a program where they're partnering people from the community to help take dialysis patients to those appointments and be there with people to advocate, to listen, to take in all the information, to write things down, to go prepared to those visits as best as people can. So trying to figure out, what the resources are around you, asking for help, and being clear about the, some of these reasons for example, a missed appointment, so you don't get dismissed.
Great, thank you. We're getting short on time already, which is hard to believe, but I'll come to each of you. Just one quick thing, Tamara, that you hope people take away from this session on how to ease this process.
It's never too late. It's never too late. Like I mentioned, it was my second time around looking for a transplant. And the second time I had to open up my mouth and ask. So it's never too late, and don't be afraid to share your information, especially with your family and your close friends.
Tanoshika?
I love that message, and I want to just echo this importance of feeling empowered. Your voice matters. If you're not getting the right answers, or it doesn't seem right, or you haven't been giving your options, for example, in one particular practice or one place, seek guidance from others of these national organizations, and these big networks of other patients and people who've been through this are there to support you along the way. So advocate for yourself and feel empowered because we are here to care for you and serve you.
Well, thank you both so much. I want to thank our audience for attending and asking questions. Up next is our final transplant session of the day, and we have some great speakers lined up. We'll talk about the post-transplant process that's coming up just a few minutes in 4:30 Eastern Time. Just a reminder that once we conclude this session, that you will see a link to a poll for a quick survey. Please take a minute, fill it out. Giving your feedback on how we're doing is really important for us as we build for future sessions. So again, I want to thank my panelists one last time, and have a great day.